Welcome back to the deep dive. Today we're getting into Holmes-Adie Pupil, sometimes called Adie's Tonic pupil.
That's right.
We've got some solid revision notes here, and the plan is to really pull out the must-know info. Make it stick for recall, especially if you're prepping for something like the MSRA.
Absolutely. We'll cover the definition, causes, who gets it, how it works, diagnosis, management, the whole lot.
Perfect. So let's start at the top. What exactly is Holmes-Adie Pupil?
Okay, so basically it's a neurological condition. It affects how the pupil in your eye reacts, specifically to light and focusing up close.
Affects how?
Well, the main thing you see is a dilated pupil, so it looks bigger than the other one, often, and it's sluggish, very slow to constrict when you shine a light on it.
Okay, slow with light.
But, and this is key, the response when the person focuses on something near, like reading, that accommodation response is often much better. It still constricts, maybe slowly, but it does constrict.
Ah, right. So the mnemonic someone mentioned was lazy light, active close.
Exactly. That's a great way to remember it. Lazy light, active close. And it usually just affects one eye, though not always. Oh, and it tends to be more common in younger women.
Interesting. So what's actually causing this? What leads to that lazy light response?
Yeah, the exact cause. It's often idiopathic, meaning we don't know for sure, but the leading theory involves damage or degeneration of the parasympathetic nerve fibers.
Oh, one's controlling the pupil.
Precisely. Specifically affecting the ciliary ganglion. Think of it like a little junction box for those nerves, and the short ciliary nerves that run from it to the eye muscles.
And what might cause that damage?
It's often thought to be post-viral. Maybe inflammation following something like herpes zoster or another virus could damage those delicate nerve fibers.
Okay. You mentioned younger women. Are they the main risk group?
Yes, predominantly. Females, typically between 20 and 40 years old, are the most common group affected.
So going back to the mechanism, the pathophysiology, how does that nerve damage translate to the pupil not constricting properly to light?
Right. So those parasympathetic nerves are responsible for telling the iris sphincter muscle, the muscle that makes the pupil smaller, to constrict. If the nerve signals are damaged or disrupted, that message doesn't get through properly, or it's delayed.
Like a faulty wire.
Sort of, yeah. Or maybe the junction box itself, the ciliary ganglion, isn't relaying the signal effectively. That viral or inflammatory damage we mentioned is the likely culprit messing up that pathway.
Makes sense.
Huh.
Now, if a clinician sees a dilated pupil that's slow to react, what else should be on their mind? What are the differential diagnoses?
Good question. You definitely need to rule out other possibilities. For example, pharmacological dilation, maybe the patient used dilating eye drops.
Right. Always ask about drops.
Definitely. Then there's Horner's syndrome. But remember, Horner's typically causes a smaller pupil, miosis, plus a droopy eyelid and reduced sweating. So kind of the opposite pupil finding. You'd also think about a third nerve palsy, an oculomotor nerve issue. That can cause a dilated pupil, but it often comes with other signs like problems moving the eye or a droopy eyelid as well. Careful examination helps distinguish these.
And how common is Holmes-Adie Pupil? Do we have numbers for the UK?
The exact prevalence isn't really well established, unfortunately. It's considered relatively uncommon, but firm figures are a bit hazy.
So, clinical features.
Yeah.
What does someone actually experience, or what does the doctor see?
Well, the classic sign is that unilateral dilated pupil we talked about happens in about 80% of cases. It reacts slowly, or sometimes barely at all, to direct light.
But okay for near vision.
The near reaction, the accommodation, is typically better preserved, although it might also be slow or tonic. Sometimes you can see vermiform movements, like little wiggles in the iris or segmental constriction.
Segmental, like only part of it squeezes.
Exactly. The pupil shape might even look a bit irregular. Symptom-wise, people might notice blurred vision, especially for near tasks, or difficulty adjusting between light and dark environments.
And isn't there a syndrome associated with this?
Yes, that's Holmes-Adie syndrome. That's when you have the tonic pupil plus absent or diminished deep tendon reflexes, most commonly the ankle and knee jerks.
Right, the pupil and the reflexes together. So how do you confirm the diagnosis? Is it all clinical, or are there specific tests?
It's largely a clinical diagnosis based on observing those characteristic pupillary reactions. A slit lamp examination is crucial to get a good look at the pupil and iris movements.
Any other tests?
Tonometry to check eye pressure is standard, maybe imaging if you suspect something else like a third nerve palsy. But a really key diagnostic feature is testing the pupil's response to weak meiotic drops, like dilute pilocarpine, say 0.1%.
And what happened?
An 80s pupil shows denervation hypersensitivity. It constricts significantly to this very weak solution, whereas a normal pupil, or one dilated for other reasons like third nerve palsy, usually wouldn't react much at all.
Ah, okay. That hypersensitivity is a big clue. So what's the management? Is there a cure?
There isn't really a cure as such, because it's often nerve damage. But specific treatment often isn't needed if it's not causing significant visual problems.
What if it is?
Well, reading glasses or bifocals can help manage the blurred near vision, the accommodation difficulty. Sometimes, paradoxically, those weak pilocarpine drops used for diagnosis can actually be prescribed to help constrict the pupil a bit for comfort or near work, though it's not common.
And you mentioned infants.
Yes, important point, if this is suspected in an infant under 1 year old, a referral to a pediatric neurologist is generally recommended to rule out other underlying issues.
What about the long-term outlook? Is it serious?
Generally, the prognosis is good. It's usually a benign condition. It doesn't typically lead to blindness or serious vision loss, and it doesn't tend to worsen significantly over time.
Any improvement possible?
Some people do find that the accommodation improves a bit over months or years. The pupil itself might actually get smaller over a very long time, sometimes even becoming smaller than the unaffected pupil.
Are there any potential complications to be aware of?
Complications are pretty rare, thankfully. There might be a slightly higher chance of developing cataracts later in life, so recommending regular eye exams is sensible. But overall, it's not associated with major long-term problems.
Okay, great. So, wrapping up for revision. Holmes-Adie Pupil think that dilated pupil, lazy light, active close response, often unilateral, more common in younger women, likely due to parasympathetic nerve damage, maybe post-viral. Remember the hypersensitivity to weak pilocarpine, and that it's usually benign. Don't forget the syndrome involves reduced reflexes too.
Nicely summarized.
And of course, for more fantastic resources for your MSRA revision, do check out PathomsSRA.com and also FreeMSRA.com.
Definitely worth a look. And maybe a final thought to leave you with. Isn't it fascinating how looking closely at something as seemingly small as how a pupil reacts can give us such important clues about the wider nervous system?
Absolutely. Food for thought. Thanks for joining us on the Deep Dive.